Hey everyone, welcome. I'm Dr. David. This is the El Paso Manual Physical Therapy weekly live stream. We're going to be talking about the worst 13 mistakes people make when trying to fix knee arthritis. And before I get into all that, we got a lot of things planned for you today. We're going to be taking some calls from people that want to get unstuck, that are trying to fix knee arthritis or other problems. But comment on here. Let us know where you're from in the world. Say hello, and looks like we got some people commenting already. We have Kathleen from Oklahoma City. Oh, you guys got a good basketball team this year. Best of luck to you guys in the finals, or wherever you guys are at right now. MZ says, hi, Dr. David and everyone. Mason here, sending best of greetings from Cairo, Egypt. Oh, so cool. So Oklahoma and Cairo are here. That's great. Kate, hey, Kate. I remember you, Kate, from Richmond, Virginia. East Coast is checking in. Chicago's here, the Midwest. That's Rebecca Burgess. Hey, Rebecca. Thanks for joining us. Santosh, I remember you, is here from the UK. Cool. The UK is checking in. Marty Edwards just became a member on YouTube. Thanks for joining us on YouTube, Marty. Congratulations. And so just so that you guys know, we have a YouTube channel membership. If you go to our YouTube channel, any of our videos, there should be a little join button. And what that does, by becoming a member, I think it's like $5 a month USD. You have priority in getting your comments on YouTube answered first over other people's comments. We try to get back to everybody's comments, but we make sure to answer the members' comments first. Thanks for joining us there, Marty. Steve Drake says, Grand Prairie, Texas, where nothing ever happens. Well, that might be a good thing. Could be a bad thing. I don't know. Depends on how you look at it, Steve. Glad you're joining us here, Steve. Doug says, I will try to call again from South Carolina. Awesome. Doug's getting ready to give us a call. Fantastic. We'll flash the number when it's time to give us a call. Who else is here? Where are you guys all from? We got Lorraine. She's got a question. She says, Dr. David, 3 years ago, I was told by my MD I have bone on bone in my left. The past year, I have noticed my left knee seems to be bowing in towards the center of my body. Question. Oof. So sorry to hear that. Well, you likely have muscle imbalances. That's what sets up osteoarthritis. When it's bone on bone, there's a lot of compression going through the joint. Just remember that bone on bone doesn't mean there's no cartilage left. It doesn't always mean that anyway. Sometimes it means that you just have a lot of compression. But the bowing inwards, that's a sign that you're just susceptible to getting that kind of problem. The first thing I would do, Lorraine, is go start our free phase 1 of the knee arthritis recovery program. It's on our website, because you can probably stop the progression of that bowing inwards by beginning to implement some of the things that we teach in our treatment approach for knee arthritis. There's a website right there. If you go to the website, you'll see Start Now for the knee arthritis recovery program, and you can begin to learn about it and see if it's right for you to go through the program and maybe even join if that's right for you. But just start doing the free stuff. Donna says, hi, Dr. David, and she's in Alberta. Canada's here. So cool. We got Jeanette from Central Point, Oregon, and the Pacific Northwest is in here. Great. Australia is here. We have Slav from Australia. Great. Thanks for joining us. And then we have Doug again says, Big Daddy Doug from South Carolina. Hey, Doug, please take my call today. We'll see. We'll let you know when the phone lines are open. And then Sweet 1983 is in New Jersey. Great. Who else is here? Marion is on Facebook, and she's here from Albuquerque. Hey, Marion. Thanks for joining us. Fantastic. And then we got Doug saying, how do you know when you need to get a knee replacement? Oh, good question, Doug. So there's my opinion, and then there's what the doctors will tell you, which is they're not the same. Other doctors will say when your x-ray, they take their x-ray and they'll put it up on the wall or on the screen for you. They'll say when your x-ray is bad enough, and what they mean by that is there's visible signs of arthritis, like they can diagnose arthritis off the x-ray. That's one factor. And then the other factor that they go into is when you can't take it anymore, when the pain's too much and when you think that you need it, which is very subjective. So we have one objective measure, the visible signs of arthritis on the x-ray, and then the other one is whenever you're ready. And I don't like that because they don't give you any guidance on how to flare things down very often. They're just like, well, try these pain medications. It's very I'll get into it today. There's a lot of mainstream advice that out there that doesn't work for people, and it really just pushes you towards having surgery. What I go by, my recommendation on when you should get a knee replacement is of course the X-ray. Obviously, there's signs of arthritis, but the second is function. When your knee cannot bend or straighten, then that is hard evidence that your joint is affected. And now it may not be able to bend or straighten for like a day or for a short time frame. That's different. You might need to just get over some irritation. But when you cannot bend or straighten it fully, and there's percentages we go into, I can get in all the details at a later time. But when you've been like that for months, that's when I'm like, all right, it's time to get a knee replacement probably. All right, guys, good question, Doug. Let's move on. We're going to talk about our list here next. So these are the worst 13 mistakes people make when trying to fix knee osteoarthritis. And as I was making this list, I was like, oh my gosh, there's so many mistakes people make. And where do I start? And I thought, let me start off with like a big picture, the main takeaway. Like if you only saw one thing on this list, let me start there. The other things are great too, though. Like they're good mistakes you don't want to make. But number one is remaining uneducated. Uneducated. And let me unpack this a bit for you here, because when I say uneducated, many of you guys here are different because you're here, you're watching me on this live stream, you might be on YouTube or Facebook or Instagram. Like you're trying to educate yourself. That's a big deal. Like kudos to you. Great job. You're doing fantastic here. But it doesn't just stop off this one video. Like there's a lot to learn. And most of the education that people do is just about what doctor's visits next. What's the next step my doctor has for me? It's really not education that you own, that you understand. It's really just knowing what steps the doctor's going to tend to take you through. And that's not helpful in my opinion, because I mean, it is in the sense of you know what to expect from the doctor's office, but it's not going to fix your knee arthritis. And so what I mean by remaining uneducated is that there's simple, basic principles about knee osteoarthritis that you need to understand so that you have a fighting chance at fixing knee arthritis and avoiding a replacement. I'm going to share them with you right now. So there's two main principles, and they both involve biomechanics. Let me explain it to you. Come on over here. So number one principle is, let me make sure I say the right words here, is that there's a muscle imbalance that is putting too much pressure through the knee joint. And when that pressure is there for weeks, months, maybe even years, as is the case in many of you guys, decades, some of you guys, that pressure buildup causes the bones inside the knee joint to adapt. They thicken. That's called sclerosis. Sometimes they change shapes a bit. That's called bone spurs or osteophytes. I'm going to say a bunch of words that you'll find on your X-ray report from your knee arthritis diagnosis. Sclerosis, bone thickening, and then you have the bone spurs, which is osteophytes. Then you'll have loss of joint space, and they're usually talking about the end of the thigh bone and the top of the shin bone. On the X-ray, they'll say, well, it's a little bit less, maybe on the medial compartment, on the inside of the knee versus the outside of the knee, the lateral compartment, or both. Those are all signs of compression that are going through your joints. And the reason mechanically that happens, this is where the medical field stops. Like they don't go this far. I'm gonna like, hey, this is the part that you really want to listen to. It's the muscle imbalances that are causing all these bone problems, bone and joint problems. So in the knee joint, you have the quad muscles that run from the tip of your knee, they attach to the kneecap, and then you have that tendon that attaches down right here. And those quad muscles come up into the hip and around the thigh bone. And then you have glute muscles on the backside of the hip, the butt muscles, and those muscles oppose each other. In other words, if the quads are working, then glutes generally have to shut off in order for the quads to work. If the glutes are working, then generally the quads have to shut off in order for the glutes to work. But if your glutes are constantly not working because they're weak, you haven't been using them for whatever reason, we can get into that, then your quads will begin to compensate, to be used extra for a weakness in the glutes. And when you're using your quads a lot, you work them out, and then you get stronger quads, which then end up putting more pressure on the kneecap. See, this is the quad tendon right here. So it yanks the kneecap against the thigh bone. And then because you have this connection from the kneecap down to the shin bone, it yanks the shin bone up into the thigh bone. And there's all this compression that's built up. That is the muscle imbalance. That is what is not explained to you guys by the doctor, by the physical therapist. In fact, they tell you, oh, you probably have weak quads, so let's strengthen the quads, which is exactly the way to make this muscle imbalance worse. This is the education that I'm talking about that is missing. And people that are trying to fix knee arthritis remain uneducated about this process, and they just blindly follow the doctor because they're supposed to be the expert in this. However, it's the blind leading the blind. They're really walking you to the slaughterhouse, literally to the surgeon, to have a surgery, to have a joint replacement and it's still probably going to hurt afterwards. It happens very often that people still have pain in their knee in varying degrees. Sometimes it's a little bit and they can live with it. Sometimes it's a lot and they regret having the knee replacement. All right, so that's the first thing. And then the second principle around this remaining uneducated idea is that when you finally make the connection and realize about this muscle imbalance, that you have weak glutes, and there's other muscle imbalances. I'm being very simple here. That's why you need to get educated. It's not a like a binary thing like, oh, I just have to fix my glutes and that's it. There's a little more to it. But once you figure out how to activate your glutes, then you need to make your glutes burn, and you need to not let your thigh muscles work so much. And that's a whole other process that takes some time. And it's usually more time than your doctor would give you otherwise, because your doctor is probably going to send you to a follow-up in a month, and then to the physical therapist in another month or two. And then if things don't work out during that time, after you've been diagnosed with knee arthritis, they're going to say, let's go to surgery. And you're 4 to 6 months into this whole process. In our program, the knee arthritis recovery program, we see the people that do the best, they're with us for 6 to 12 months. And they fix the problem. They fix the root problem. And they're fixing their knee arthritis and they're avoiding surgery. We're implementing a cure to knee arthritis essentially, but you have to go against mainstream medicine and you have to educate yourself about this stuff. So that's why this is, I can't emphasize enough this point. You have to educate yourself, because if you remain uneducated, you're making a mistake. All right, let's do number 2 here. Oh, I love this one. You guys get told about this all the time, and it doesn't make sense when you really unpack it. Low impact exercise. Everyone all over the internet, doctors and physical therapists, they say, oh, you have knee arthritis? You should be doing low impact exercise. This phrase is plastered everywhere. Low impact. Walking is a great low impact exercise. Cycling is a great low impact exercise. Elliptical, get in the water and do exercises. Do these exercises where you're lying down rather than standing up, because it's less impact. And the thought on the superficial level, it kind of makes sense. That's why people don't think too much about it. They say, well, yeah, because I'm not, if I go running or if I do some jumping activity, that's a lot of impact on my joints. That is not low, that's high impact. So it's going to worsen my arthritis, because to some degree, most people are like, yeah, there's wear and tear in my joints, there's pressure in my joints, and I'm going to worsen it if I do higher impact stuff. And maybe you felt it if you've done a little bit of high impact activity. So it makes sense superficially. But where you run into problems is if you don't get educated about the muscle imbalance and how to make the right muscles burn, you're going to pursue elliptical, cycling, like on a stationary bike, or maybe Tai Chi or yoga or other physical therapy exercises, like where you lay down and pick up your legs this way and that way, or you use this rubber band on your knees and you open your legs this way and that way. Like I'm being kind of general here, because a lot of these exercises, they don't make your glutes burn. they miss your glutes completely, which means you're not solving the root problem and you're never going to resolve knee arthritis. You're just going to actually slowly make it worse because the muscles that you do use in low impact exercise are probably going to be your quads and some hip flexor muscles, the muscles on the front and sides of your hips that don't actually fix the imbalance. They actually feed into the imbalance. And so even though you're doing Tai Chi and it feels good, right? You go on that slow walk or you get in the water and you do these easy exercises, you do the yoga because it involves some stretching and it kind of feels good. But over time, over the weeks and months, over the years of committing to these things, you don't actually get better. Maybe in the short term, you have some improvements like, oh, I feel a little looser today. I feel like I did something, pat on the back. I got to exercise, whereas I hadn't been because my knees are hurting. But then after a few weeks of continuing to cycle, continuing to get on the elliptical, knees kind of get worse. And then it feeds into this, it feeds into the words that most people in the medical field will tell you, which is, oh, it's an age-related problem. You have osteoarthritis? Well, how old are you? 70-something. Well, yeah, this is an age-related problem, they'll say, and I don't subscribe to that because your body has the ability to heal and change depending on what inputs you give it, depending on what you go through, what exercises, what movements you do. And so if you're always doing low-impact exercise at the direction of doctors very often or physical therapists, but you're missing using your glutes, the inputs you're giving your body are such that they will make the imbalance worse. Versus if you do glute-focused exercises, that might be low impact. You know, they're not making your joints worse. You're going to be fixing the root problem and setting yourself up to then fix the long-term arthritis problem, avoid a knee replacement, and get back to doing all the things that you love to do. So it's less about general low impact exercise and more about precise exercises that fix the root muscle imbalance. So there you go on low impact exercise. Oh, we have Doug made it through on our line. Let's talk to Doug. I have a call here. Give me a moment. Doug from South Carolina about a question about a knee replacement. Hey, Doug, this is Dr. David. Can you hear me?
Yes, sir. This is Big Daddy Doug from South Carolina. How you doing?
Hey, Big Daddy Doug. I saw your comments on there. Thanks for joining us today. I'm doing great. How can I help you?
Well, just I'm trying to not commit to this program again. I'm trying to surrender because that's a lot. I like that to say that right there because I'm just trying to re-engage. I've had about a year of cortisone shots. I'm 295. I know I need to get down to 250 or a little bit lower.
Yeah.
I'm trying to re-engage with your program. Just needed some suggestions with the protocol of that. I did sign up for the old, a few years ago,
yeah,
the arthritis program, but I'm trying to get maybe a correct or maybe a protocol to go forward. I did get a gel shot a week ago, but I know all those are just an improvisation, and I have had benefit from the things that you said to relieve pain. I believe what you're saying. I believe in you. I just need to re-engage and walk down the trail, and I'm looking forward to talk to your staff later.
Yeah,
maybe some ideas of encouragement on your side. That's what I'm kind of looking for because I spent about an hour with glutes this morning, just trying to focus and trying to do these things. So thank you so much for taking my call. And I could talk forever, but thank you for your encouragement.
Absolutely, I'm glad you're getting those glutes active and you're re-engaging here. I could tell you don't want to have a knee replacement. Nobody does, right? But do you mind if I break it down a bit for you so I can get you some help here? Okay, so absolute first thing, if you don't have good glute activation, work there and then begin to continue to get better glute activation and use your glutes while you're standing, walking, and all that. But you did mention that you're at 295 pounds, right? And so can you calculate BMI for me? So let's get your height because I want to get a BMI out of this here. You're at 295 pounds. How tall are you in feet or inches? 6'2"?
6'2".
All right, so that'll be 74 inches. If you guys can help me calculate a BMI. The reason why I'm getting the BMI is because we need to determine if you're at the right cutoff. So they're telling me here it's 38. Your BMI is 38. So what we have found over the past couple of years of doing the knee arthritis recovery program is that if your BMI is above 35, so which you're at 38,
yes, sir.
it's going to be a higher priority for you to focus on the weight loss right now. I love that you brought up this call, because actually one of my talking points today for the teaching, and this
Good.
For me, this clears it up for you, because I don't want to waste your time. I don't want you to get false hope. And this program does work, but your weight currently is enough to be a factor. And here's the thing, Doug, it's easier on your joints right now to drop the weight than it is for you to pick up the strength. Once you hit 35 or lower, then things shift, and it's going to be more impactful for your knee health to work on the strength and less so on the weight. Does that make sense?
Yes. I'm willing. I promise you, I'm willing.
You're not too far away either. So it's good to be working on the glutes right now, but what I would do is go do the work that's needed to drop that weight down. If you need to talk to a healthcare specialist, a doctor, nutritionist, somebody that might help you with that, or if you already know what you got to do, it's just a matter of doing it, I would focus on that. But just I don't want you to go through the next days of your life, the next weeks of your life, saying, let me focus on this knee program that Dr. David has, and then it's really not the best thing for you to be focusing on. You should be focusing on the weight loss at this time.
And so in summer too, I have a ministry of hospitality whereby I'm coming up and down for the legs all over the house.
Yeah.
And it limits me to what I can or can't do, because those knees are engaging. So I need to move toward mobility. I'm at 62 years old. And I need to. This is the time. I believe this is the time. Wouldn't you agree?
Oh yeah.
To go forward.
Yeah. It's only going to get harder. I would get the weight under control so that habit is developed too. And chances are, even just dropping the next 10, 20, 30, 40 pounds, even if you didn't work on the knee arthritis issue, you would feel better in your knees. But then comes that point where if you continue to lose weight, it'll be good for you on so many other health fronts, but you won't make as much progress on your knee health. That's where you need to start hitting this program hard.
Okay. And then regroup on the new and updated program, or still use the old program. The old program was a few years ago when I did pay the money to buy that and everything.
Good question. Yeah. So the differences are that the old program, and just for everybody's sake out there, what Doug's referring to is when we first started the knee arthritis recovery program, it was just a curriculum. It was just a bunch of videos of me walking you through everything step by step on how to heal your knee arthritis. That's what you still have available to you, because you should have lifetime access to that. What we've upgraded it to now, Doug, is you get that plus a whole lot of accountability and other services. There's a private community. We have breakthrough sessions, which are one-on-one sessions with our recovery coaches. There's opportunities to work with our specialist PT and myself too. There's weekly group coaching calls. There's office hours every week as well. There's all these other features. It is a membership, but you get all this help, a lot of help, and it's shown to be very successful. That way you're not on your own, because that's what it was like for people that bought that program that you have is we were figuring it out, seeing how we needed to set up this program to best help people. And I first need to get the curriculum built, and now we've added all this other stuff to it since then.
Well, that's great. Well, I do appreciate your time. So I can reach back out to the office or talk to them later about kind of a protocol of revisiting that with maybe a new program, but go first as far as weight, like you said.
Right.
That's that. And then secondary, still work on my glutes. There's no problem.
Yeah.
Maybe my knees might be this way and that way, but I can still work on something, can I?
Oh yeah. You should. You absolutely should. But I just would hate to tell you, focus on our program 100%, and that's going to fix you. When your weight is at a point where we need to address it a bit, and you're not far off. Once you get the weight a little bit down a bit from where you're at, then it's time to start to put immense focus on the knee arthritis recovery program.
Is there any other way to figure out what a proper weight would be? How do you research that? What would I look under? Because I don't know what a good weight for my weight.
Absolutely.
15 or something crazy.
Well,
that seems like
I'm the same height as you. I'm 6'2", and so we're both decently tall. My ideal weight, now this is a good question, because you have to talk about builds. Like I'm built like a football player. I mean, I could lift more weights. Like I put on muscle pretty easy, but I am not a scrawny person. I'm not a slender person. That's a better way to put it. Where versus some people are slender and tall, and they're going to naturally just weigh a lot less than me. So for me, what I found a comfortable, like a comfortable weight that according to my body size, so I'm saying this for you because you're the same height as me, it's probably going to be somewhere between 210, 220. If you had a more slender build, then it might be more like 200, 190, 200. It just, you have to consider that. But to get to 35 BMI, you're probably, you might need to check me on this, but you're probably gonna need to be like around the, which I think what you said, like around 250, 260 range to get to that 35 BMI. But that's still technically, if we're just going by BMI strictly, that's technically obese according to the BMI chart. Oops, I lost you on the speaker here.
Well, thank you so much for taking time with me. I just really appreciate it. I will reach back out with the company. I mean, with your group there, and try to revisit that, because I felt good with the shots. I let that kind of be until it wasn't good, and I've just got that shot last Thursday, and now I'm in pain, and I didn't get a lot of good advice from the doctors, and it was just, nobody told me, just go home, you'll be okay. And there's a lot of other things that needs to happen after a gel shot. So I just was kind of discouraged about that. But thank you for your hope that you're giving so many of us out there, and encouragement. If we'll just kind of do this thing called listen, we'll be okay.
I love it, Doug. Well, thank you for joining us here, Big Daddy Doug. I'm going to let you go, okay? Thank you so much.
All right, thank you again.
Yep, bye-bye.
Yes, sir. Bye-bye.
Thanks. All right, guys, coming back over here. Awesome call by Big Daddy Doug. I appreciate your honesty, Doug, and you sharing your weight and all that. That's not easy for everybody to do, but it's super beneficial for everybody on this call, because now you guys, we got to talking about weight a little bit, and I'll talk to that topic a little bit more in my list here. But let's answer some comments first. Let's see what questions you guys have so far based on my idea of remaining uneducated and low impact exercise, or whatever other questions you guys might have. Santosh says, my doctor told me it's the age. Yeah, they say that's what they get taught in school. That's why they're saying that. They get taught that knee arthritis, any kind of arthritis, is an age-related thing. And it makes sense to them, because what they're seeing is people don't get arthritis, typically osteoarthritis, until they're in their 50s, 60s and up. Occasionally you see it in their 40s. But where I differ, what I'm saying is it's a pressure over time problem. In other words, your joints are smashed because of the muscle imbalances, and the longer they remain smashed, the more likely you are to develop osteoarthritis. But a question I always have is, well, how come some people get it on one side versus not the other side? Because both knees are 75. How come only the right knee has arthritis? And how come the hips don't have arthritis? Like, if you're the type of person that's going to get arthritis and it's age-related, we should be getting it all over. There's a lot of holes in this theory, but when you apply the muscle imbalance concept to this, then it makes sense. Then it's because you're right leg dominant, or the way that you live, you tend to use your right leg more, and that's causing issues, or less, that's making it weaker on that side. There's all these variables to look at that are more individual, but it fits more so with the muscle imbalance concept that I share. Good question there, Santosh, or comment. With all the LOL emojis. Evelyn says, thank you so much for educating us. Doctors hate me because I challenge every other word that comes out of their mouths. I'm building monsters here. Evelyn, you guys be nice to your doctors. They're doing the best they can with what they know. I always say that, and I mean it wholeheartedly. But they just don't know arthritis very well. And, you got to do what you got to do. You got to take care of your own body. You're your own best advocate. You got to be very careful with what you say to a doctor, especially if you're stepping on their toes. And so just be careful. Make sure you have rapport, because you're gonna take a hit on that relationship if you do that. Make sure that it's a doctor that's willing. Otherwise, I would smile and nod and say, okay, yeah, whatever you say, and then just act different, but not, poo-poo on their ideas. You guys got to figure it out. That's a tough one, Evelyn. Jill says, can they work together? I'm not sure what she's talking about. What's they? That's what I'm confused on. If you can comment, Jill, that'd be helpful. What is your opinion on gel injections every 6 months? I'm going to be talking about it today a bit more, but my opinion is it's only short-term help. That's why they want to do it every 6 months. That's the term, 6 months. Sometimes a little less, sometimes a little bit more. But it's not solving knee arthritis. It's just buying you time, short-term. Brooklyn says, no surgeries for me. They want both hips and knees. Oh yeah, they love to do surgery. Well, they're trained on it. Surgeons are trained to do surgery. And so when they see an opportunity to do it, they're usually, almost all of them, I really think so, are thinking out of compassion, and they want to help people, and they want to say, I have this skill. I know how to replace joints, and you have arthritis on your x-ray and you're in pain. Maybe I can help you. That's, I think, the honest angle that they're coming from. But there's a lot of new information out there. There's the way that I'm thinking about this stuff and sharing with you guys, and we're seeing success with it. And that's just, it's not taught in their schools yet. So that's why you get that kind of response from doctors. Dr. Lyon says, could these issues cause the affected leg to be slightly shorter than the unaffected leg? Oh yeah, that'll happen. You get leg length discrepancies. That's what we call it in the medical field. Because of the muscle imbalances, the way they yank on your pelvis, your hip bones, they can shift your bones. You can get SI joint problems and lower back problems, and it can cause a real leg length issue, like where you're a half an inch or even an inch shorter on one side versus another. And it's because of the muscle imbalances. I just had a patient I treated last week. I'll be seeing her again this week, who had the biggest imbalance, the biggest leg length discrepancy that I've seen in a long time. It was like an inch, a little over an inch. That's a lot. And after I did my hands-on stuff, she was even, perfectly even. And then what I said after that was, now you got to get your abs and your glutes stronger so that it keeps. And she's working on it. She said she feels a little uneven since then, but it's going to take some time for her to get the ab strength, the glute strength, to maintain the pelvis symmetry so that she's not shifting so much and causing those leg length problems. We see that for sure. Kimberly's here. Hey, Kimberly. She says, is there any help with the quad muscle stretching over knee if that leg is about 1 inch longer? 2 surgeries, it always feels so tight. I think you can get short-term help from stretching the quad, especially after surgery. So about stretching, like I'm not a big advocate of stretching. I'm not against it completely, but I don't recommend it highly either. If you want to stretch because you feel tight, I'd say go for it. But what I always say is, if you are trying to stretch thinking that's going to solve your problem, I wouldn't put a lot of money on that idea. It's only short term. It's not going to solve the long-term problem. But in your case, if you had surgery, you probably have muscle weaknesses that need to be addressed, because the muscles usually get tight when they're overused, and muscles get overused when there's another muscle somewhere else that's underused. That's the muscle imbalance. So the root problem, the long-term fix, is get the underused muscle stronger so that the overused muscle isn't being overused. That'll reduce the tightness. But in the short term, by all means, Kimberly, if you feel like stretching is beneficial, go stretch. I would also use a massage gun on that muscle, because sometimes it just needs to be softened. It needs to be, what is that called when you smash meat? It needs to be tenderized with the massage gun so that it can loosen up. And that might be more effective than the stretching for some people. The stretching could loosen up the joint, but it can also compress the joint. I like tenderizing the muscle with the massage gun because it doesn't tend to affect your joint as much negatively. It tends to affect it positively. Good question, Kimberly. MZ, they said their name earlier. I forgot. What specific exercise can I do to improve degenerated posterior horn of the medial meniscus, osteoarthritic changes, and mild joint effusion resulting from sudden heavy activity on mildly bowed legs? Whew, that was very specific. Sounds like you're listing MRI findings here. I would look to fix the muscle imbalance. As far as specific exercises, anything that involves fixing the glutes here, because all those signs that you said right there, the degeneration on the posterior horn of the medial meniscus, mild joint effusion, osteoarthritic changes, those are signs consistent with a muscle imbalance being present in the knee joint for a while. When that happens, you get compression in the knee joint, and it's usually from the quads being overactive, and it's because of the weak glutes. This is where the education comes in. You need to have this knowledge in your head so that when you go do an exercise, you can apply your knowledge to the exercise. If you just go do an exercise blindly and say, the PT said to do this, my orthopedist said to do this, my doctor said it, the internet said to do this, and you're not really thinking it through and putting it through the filter of, does this fix my muscle imbalance? Then you're potentially making your knee problem worse. So when you ask for specific exercises, it's hard for me to give you one. You have got to get the education so that you can then determine if this is a good exercise or not, because there's a lot of good exercises for you. There's also a lot of bad exercises for you. There's a lot of good exercises for you later when you're better, and there's a lot of bad exercises for you today that will be good for you later. Good comment there. Good question. Kate says, most important teaching you give is to stay on the level that you're on. No PT says that. Yes, you're learning this, Kate. You're on with me, Kate. Everybody take notes from Kate here. That is huge here. Where's the sign? Big deal. This is part of the education. Kate, you struck a chord in me. I love this, Kate. You have to stick in the right. This goes back to the comment before about the meniscus too, is you're asking what specific exercise is going to fix this meniscus problem or arthritis problem in the knee or hip arthritis problem or back problem. And if you're looking for one exercise that you're going to carry through this whole phase, this is the phases of healing, you're going to fail. There's certain exercises you do here, and then once you're out of this phase, you do certain exercises here, and then they change again in the next phase and the next phase. It's a process. That's the better way to look at this, is it's a process, and medical people don't understand this. That's why Kate's saying this right here, is PTs are just thinking, yeah, just do quads indefinitely and walk. And if you can do bike, great. And they just stay on that without really thinking about the phases of healing like I've put in the program. All right, we're going to take a call from James in Pensacola. Hey, James, it's Dr. David here. Are you there?
Yes, Dr. David, this is James.
Hi, James. Nice to meet you.
And the education you put out.
Thank you. I appreciate it. Glad you're benefiting. Hopefully you're benefiting. How can I help?
Well, this might be a simple question for you, but
That's okay.
When we flex the core to do exercises, bridges, and the squats,
Yeah.
do we flex the upper and the lower abdomen?
Got it. Do we flex the upper? So let me just repeat the question to make sure I have it straight. When you're doing exercises like bridges or squats and pretty much any exercises, and you're trying to flex your abdomen, do you flex the upper and lower abdomen? Is that your question?
Yes, sir.
Got it. Got it. I would focus. Here's my answer. I would focus on trying to get the lower abdomen as best as possible. I say that, and I don't want to stress you out, especially if you're a type A type of person, the person that wants to do everything perfectly. I don't know. I'm just saying this out loud for the type A's out there. You're never, ever going to 100% only get the lower abdominals to work and not the upper abdominals to work. They work together. What I'm looking for, though, is for you to bias, for you to get more lower abdominals than upper abdominals. If you can successfully say you biased, you did get your lower abdominals to flex better, then you're on track. But if you went through an exercise like, say, bridges or a direct ab exercise, and you felt your upper abs above your belly button get more tired than your lower abs, that's a fail. And you need to practice doing this so that you get the lower abs correct.
Okay, yeah, that last scenario was mine. I think I was doing only the uppers.
Yeah.
Bring in the lowers and definitely make that complete.
Yeah, I love that you're struggling with this. This is good, James, and that you're asking questions because you're figuring this out. You need to practice and get reps, and it just takes tons of reps and fine tuning and people. And even when I say reps, I do mean literally hundreds, if not thousands of reps, but not just thoughtless reps. You have to concentrate and pay attention in order to tune in and feel those lower abs truly work more than your upper abs. So it's very conscious. It's more thinking than it is exercising, especially at the beginning.
Got that. I do drift in and out, but I definitely focus on the tension part of it.
Good. Happens to the best of us. Great. Glad you asked that. Anything else I can help you with, James?
That's it. Great. Thank you for your time, Dr. David.
No problem. Have the best day. Keep getting better. Goodbye.
Will do. Thanks. Bye.
Great question from James there. Fine tuning. This is part of the education part here. Is we're fine tuning which muscles are working, and this just isn't taught in normal healthcare. They just say, just go do the exercise. Make sure it looks like you're doing the exercise correctly. And you can be doing a sit-up exercise and working out a different muscle. You could be doing a squat or a bridge, and your squat might look just like somebody else's squat. Your bridge might look like somebody else's bridge, but you're using completely different muscles than the other person. Somebody else is using more hamstring, the back of the thigh, and you're using your glutes. You might be trying to do a squat and you're using your quads, and somebody else is using their glutes, even though it looks almost identical. So good question there, James. Super important. All right, let's get back to the list here. We were on low impact exercise. So we talked about how one of the mistakes people make is remaining uneducated. They don't understand the muscle imbalances. They don't understand the biomechanics and how to fire the right muscles and make that muscle burn. Those are the principles. Then low impact exercise is just thrown out loosely by doctors and healthcare professionals, and they don't really fix the muscle imbalance. They're just saying, just go move, even though you're feeding into the problem. For number 3, related to low impact exercise is walking. One of the biggest recommendations people in healthcare make is go walk. The doctors will tell you, and they'll say it's a low impact exercise. Walk. Everybody can do it. All you need is a pair of shoes. You can do it barefoot at home. They make it seem so easy. And here's the thing: is I'm very against walking, and I'm also very for walking. The difference is, can you use your glutes when you walk? That's the only question you have to answer. If you have knee arthritis right now and you're thinking of going to start a walking program at the instruction of your doctor, your physical therapist, and you think to yourself, can I use my glutes? Like, do my glutes get tired when I walk? Can I consciously tighten my glutes independently, right from left, as I take steps when I walk? If the answer to that is no, not consistently, then you should not be walking right now for exercise to help knee arthritis. Walking to help knee arthritis should only be done if you can flex your right glute independently from your left glute, and your thigh muscles aren't trying to take over too. You're not compensating with your thighs. It should just be glutes. And then you have to practice taking steps so that, let me show you, so that when you take a step, you step with your right foot, your right glute tightens up, not your left, just the right. You don't want both to flex at the same time. You just want this side to flex. And then when you step with the other leg, with the left leg, then my right glute should relax and the left glute here should tighten up. And that's how walking should be. It should be alternating glute contractions. Alternate to the right when I step on the right, then the left tightens up when I step on the left, and so forth. If you can walk like this and truly feel your glutes working, like getting a little bit of a workout, then walking is excellent for you, because every step you take like this is productive towards fixing the muscle imbalance and keeping you from overpressurizing your knees. It's good. But if you cannot walk like this, if you're not using your glutes, then you have to ask the next question of, well, what are you using to walk? Did you never feel your glutes working when you walk? What are you using? By default, it's just about always your quads. You're compensating with your quads. And if you go on a longer walk and you pay attention to what muscles are getting tired, it's probably going to be your thighs, your quads. And then if you think of the biomechanics, if you think of the education and how the quads are pulling on the kneecap and pulling on the shin bone, compressing your knee joint, it's no wonder why you get to walking 7, 8, 10,000 steps and your knees kind of feel worse, even though when you're following doctor's orders and walking for exercise. You can't be doing that. You got to listen to your body. Fix the walking, make it glute dominant. All right, number 4 here. Aquatic. I'm just going to write aqua exercise. This one has had so many, research studies showing that it's beneficial, But it's the same idea. It's a low impact exercise. But there's even physical therapy clinics out there that have built-in pools. There's all these senior citizen centers with pools where they have aquatic aerobics and aquatic exercises. And the doctors will recommend, the physical therapists will recommend, they'll say, get in the water. It's going to feel good. And that's true. It will absolutely feel good for your knees to get offloaded by the buoyancy of the water. And all of a sudden you can move. That does feel good short term. But now if you're trying to fix knee arthritis for the long term to avoid a knee replacement, and you're pursuing aquatic exercise on a regular basis, you're doing aquatic physical therapy on a regular basis, and you're on some of these places, they have an underwater treadmill. It's underwater. There's a conveyor belt and you walk on it underwater, like you're going on a walk on land. And the idea is to offload you while you're walking. But did you get told to use your glutes? Because if you're not using your glutes while walking, we just talked about that, you're shooting yourself in the foot. You're using your quads. You never fix the imbalance, even though you're underwater. It's the principles that matter here. It's do we understand the muscle imbalance, and are you targeting the right muscle when you exercise? Aquatic exercise could be beneficial if it follows those principles, but usually people aren't guiding you to follow those principles. They're just saying, just get in the water and move. Just get in the water and do quads, squats, or walk, or there's underwater bikes too, or just go swim, freestyle swim. If you're a swimmer growing up, you were on the swim team as a kid, bring it back and go swim now that you're in your 60s and beyond. They just give you that instruction, and there's no education on how to fix the imbalance and how to make sure you're targeting the right muscle. So I would say stop doing aquatic exercise unless you're working your glutes there. All right, number 7. Hopefully we're spurring, I'm sorry, number 7. Number 5, hopefully we're spurring some good comments here from you guys. Ask some questions. The magic exercise. I was already talking about this a little bit. Magic exercise. People are always looking for the magic exercise. I get asked all the time, what's the one exercise that's going to fix my knee arthritis? The PTs. Yeah, if you just work your quads, it's those knee extension machines. It's the leg press machine. They'll pick an exercise. It's the bike. And I think that's so false. That it goes back to this, there's not one thing that's going to fix you. There's phases of exercise depending on your symptoms. So just to explain this in case you've never seen this before, this is a chart pulled out of the Knee Arthritis Recovery Program, which you can access for free. We have it. You can access phase 1 for free. You can access this chart for free. But you're seeing it right now. You can take a screenshot if you like. There's certain criteria. And if you just meet one criteria from a lower phase, you're in that phase. If you have swelling 4 to 7 days, pain at night, pain during the day as well, if you can't be on your feet for more than 10 minutes, and if you can't get your glutes to activate the way it says right here, you're in phase 1, even if you just have one of those things. There's some people that have no pain whatsoever, no swelling, but their glutes just don't work right. They have no business doing harder exercises. We need to do the basic glute activation exercises first before we progress into the next phase. And so if you're trying to do aquatic exercise, you're trying to walk for long periods of time, and you can't even be on your feet for more than 10 minutes. If you're trying to do quad exercises because you were told, or somewhere on the internet, they said that it's all about this quad machine or this special squat that nobody's ever seen, that somebody new invented. There's no one exercise that's going to fix the entire problem. That's what you have to understand. You're looking for the holy grail of knee arthritis exercises. It's not just one thing. It's a journey. It is a process. So lose the idea, because you're making a big mistake if you're thinking you're going to find the magic exercise. All right, number 6 now. I'll fit it down here. Let's go purple to keep the pattern. If y'all hanging in there, y'all give me a thumbs up if you're hanging in there on the chat. Is it right, number 6 here? Give me a thumbs up in the chat. So now we're going to get into relying on pain meds. That's a big mistake. Give me a thumbs up. Oh, we got some flexi arms too. Glutification. I see that on there. Awesome. Relying on pain medications. People will pop them like it's candy. They'll have them in their purse. They'll have them handy. And they don't even realize the full over-the-counter medications, what I'm talking about. Oh, you can go to the store, go to the pharmacy, go to the grocery store, and find very strong medications that can do some serious damage to you. And people will take them because they do take the edge off. There's commercials, right? There's osteoarthritis, Aleve, Excedrin. Those are ibuprofen, forms of ibuprofen, non-steroidal anti-inflammatory drugs. They're anti-inflammatory drugs. They take the edge of the pain off, but at the expense of your stomach, your kidneys, your liver. Now, the medications are great. Like, let me say this clearly. Medications are an amazing invention that are landmark. Like, it's incredible what they've done with medications when used properly. Knee arthritis is not an infection. You can't just take an antibiotic and get rid of it. Knee arthritis requires you changing your body a little bit, working out your glutes better, fixing the muscle imbalance. In the short term, if you understand, if you have the right education about this, and you realize that I'm just going to have a hard day today, I have to do all these hard things. I have to be on my feet. I have to work. I have to take care of people. It's a holiday and we have people. There's things that are important in my life that I need to take care of, and it requires me being on my feet, and I am going to probably take a hit on my knees. Then I would suggest taking the pain medication. Another scenario is it's been weeks that I've been in pain. I don't feel good. I am grumpy. I am not acting myself. And there's people around me that I love and care about that unfortunately are dealing with me right now. And I'm not acting myself. I'm not myself with them, and they're feeling it. And they don't like me right now. That might be a good time to take a pain medication. But you better have a plan to fix the problem long term. Educate yourself and make sure that you're not doing any of these other mistakes too. Another situation is I don't sleep at night. I am in pain all night long, and I get this much sleep when I should be getting this much sleep. That is not good either, because you heal at night. There's a lot of important processes that happen while you sleep, and you need that rest. If you're not getting it, it might be a good idea to take some pain medication in the short term. Where we run into problems is if you begin to rely on it, and you're taking it every day. You're taking it several times a day. Not good. That's a clear sign that you need to change your approach and figure out a better solution for your arthritis. All right, I'm gonna keep going here to the next one. We're on number 6, number 7. We got, on the same thread, relying on injections. So you realize maybe the pain meds aren't a good idea, and you're thinking, but I get relief. It does work. Let me go to the doctor and ask for an injection, for a corticosteroid injection. That's a common one, like a cortisone injection. There's other medications that they'll inject out there. What it is, it's just medicine that they're injecting directly into your knee joint to get the same anti-inflammatory and pain relief effect. They're stronger medications usually, and because they're going directly into the knee joint, rather than you taking a pain medication by mouth and has to go through your gut and through your whole system, it's a little less targeted, a lot less targeted. This is way more targeted, so it tends to be more effective. And people, instead of getting hours, maybe a day of relief with pain medications, oral by mouth pain medications, injections tend to give you relief more on the time frame of weeks, if not months, 2-3 months. But they're still short term. This is not making your knees, your glutes any stronger. It's not making your quads activate less. It's not teaching you to move better. Those are the things that need to happen to fix knee arthritis for the long term. This is merely buying you time, more than if you take a pain medication by mouth. So not a good idea to rely on this, especially because of the side effects. The side effects are a little bit different than pain medications. What you'll get is if you get a corticosteroid injection every so often, there's rules on this now. Like, the doctors aren't supposed to let you do this for more than, I think, 3 times in a year, maybe 4 times. I think 3 times is what it is. Because what they have found is that you're more likely to get tears in your ligaments and tendons and damage to cartilage, because A steroid injection actually breaks down connective tissue, which is what your ligaments and tendons are made from. And the reason that happens is because it breaks down the first stage of healing, which is inflammation. You need to go through inflammation in order to heal. Just think about it. If you cut yourself, if you get a cut on your skin, the edges of the cut become inflamed. They're tender, they get red, they get thick. That is inflammation. But when you're chronically inflamed, as it is in knee osteoarthritis, we need to remove the aggravating factor. This is not removing the aggravating factor. What needs to happen is you need to fix a muscle imbalance. That's removing the aggravating factor. So this is short term. Can't rely on it. Doctors won't let you usually. There are ways that people sneak around it, but they shouldn't be doing that because you're going to get a tear, which is going to be a worse problem. All right, number 8 here. This is a growing field. People that are relying on regenerative medicine. I'm just going to write regen medicine. That's a mistake. And here's why. What I mean by regenerative medicine is your stem cells, PRP injections, what was the other one? Hyaluronic acid injections, the gel shots. Those are all other kinds of injections that are not direct pain relieving injections, because the idea behind these injections is that you're improving the health of the cartilage inside your knee. You're trying to put down new cartilage cells, even like with stem cells. You're trying to stimulate healing to happen. And the idea is great. I think it's a fantastic idea, actually. The problem is it doesn't solve for the pressure. And if we're going back to the basic principles from the education here, it's a biomechanical issue where there's a muscle imbalance and you're not targeting your muscles correctly, so you're over compressing your poor knee joints. Where's my knee joint? Let me grab it. Quads are just pulling your kneecap against your thigh bone here, and then your shin bone is being smashed up into your thigh bone as well. And so if we stick a needle in here and inject stem cells, and you get brand new cartilage cells developed on your knee right there, but you still have big quads that take over everything, your brand new stem cells are going to get smashed. The PRP is only going to last so long. The gel shots aren't going to have that long of an effect because you're still compressing everything from those quads being way too active. And so you just have to understand that if you're doing regenerative medicine, great. It's not a terrible thing. It's just short-sighted. You can't say, I'm going to get these stem cells and everything's going to be good. I'm not saying never do it. I'm just saying if you want to do stem cells or PRP, whatever it is, that's okay. Just understand there's a muscle imbalance that you need to fix in order to make those stem cells actually work for the long term. And the doctors that are doing regenerative medicine know this. They don't know about the muscle imbalance. They typically don't know that. That's stuff that only I talk about, apparently. But they know that the stem cells don't last very long. They'll say, come back in 6 months, come back in a few months. They say, come back. They want you to get the next PRP injection or the next gel injection because they're thinking this is an age-related problem and our stem cell technology just only lasts this long. And they're not even thinking about the muscle imbalance. But I think that's why these processes don't last very long. All right, guys, let's take a break from the list here. I have a few more things I'm going to talk about, but let's see what comments you guys have, what questions you guys have, so that we can make sure to not leave you guys stuck here. Let me stay hydrated too. That's a mistake I didn't even write on this list, is staying hydrated. A cartilage is like 70 or 80% water. People don't drink enough water usually. Kate says glutes are your strong foundation. Absolutely. 1000%. Kate, you're going to win. You're going to fix your problem, Kate. You're getting this. Jance Gunjan says, I am recommended to walk backward for 15 minutes twice. Is this right? Oh, as if walking forward is already terrible, is what I'm saying. You know, if you're not glute walking, because remember what I said here. Walking is only good if you can make your glutes work during walking. I have yet to figure it out. I've tried it too. I have yet to figure out how to get your glutes to be active in backward walking. It's even harder than in forward walking. So I think it's a terrible idea to do backwards walking. It's been promoted on the internet quite a bit, and some people might get some short-term relief, but I don't think they're fixing the root problem because it works your quads out tremendously more to do backward walking. And I think it's seen as some like magic exercise thing, like it's a new thing. Who thought, well, backwards walking? It's so impractical, and from my perspective, kind of borderline dangerous. All these people out there walking backwards are usually doing it on a treadmill, which, okay, you got the treadmill arms around you, but your treadmills are not designed to be walked on backwards. And so I hope you guys are safe out there that are trying backwards walking on a treadmill and then walking backwards out in public or wherever you're at. I mean, you could fall and bump into things and run into bigger problems. We are just not practically designed to walk backwards, and it does not use your glutes very well. I am 100% against it. Should not be walking backwards. And why 15 minutes? What's the reasoning there too? I'm not getting mad at you, Gunjan. I'm just, the idea is what I'm bothered by. People are just finding something new and it looks like a magic exercise, and they're saying, go do this thing. It's going to fix your knee arthritis. No, it's not going to work. What else have we got here? Oh, thank you. My staff sees me melting. I get passionate and I get hot and sweaty as a result of this. It's a little hot in this room too. All right, we got Julie Parker. Hey, Julie. She says, standing in one place for very long is a huge problem for me. Yep, absolutely. I would walk in place using your glutes, shift your weight back and forth like left to right. And when you shift to your right, tighten your right glute. When you shift to your left, tighten your left glute. There's things you could do. There's things you could do for sure. You just got to get creative. Use your glutes. You're gonna get through this, Julie. You're gonna fix this problem. Cat W1C says, I feel like I'm having a hard time getting my bad side glute to activate. Yeah, that happens all the time, Cat. There's going to be a side, your left or your right. For me, I have the same thing. I have my left glute. It does not activate as good as my right glute. And my recommendation for this, by the way, is because people will say, well, my right glute's stronger than my left glute, or vice versa, whatever it is for you. Should I just work on my left glute? Should I just work on the left side? And my advice is no, just work both. Because you're probably still going to have an imbalance left to right that you'll live with just fine. But if this is your threshold, that like if you're below this line, you're in pain. But if once your strength goes below that line, you're in pain. But above that line, you're not in pain. I'd rather you be above the pain line and still have a difference left to right in your strength. You'll be fine. You'll feel great. No problem. You're just going to feel when you work out that your left doesn't work as good as your right. That's okay. Good question, Kat. Cindy Knight. Hey, Cindy. She says, what should you do when you get overinflamed just to help get back on track? Oh, great question. The information we have in phase 1 for the knee arthritis recovery program, which is free on our website, that is loaded with things to do if you're highly inflamed, because that is what we talk about doing in step 1. Most people that are dealing with arthritis, like think about it. When you go to the doctor, it's bad usually. It's probably 9 out of 10 people that go to the doctor for knee pain, they're not going prophylactically, like before it gets really bad. The 1 out of 10, what you guys that are really good are actually doing it. But 9 out of 10 people, they're like, I'm desperate. Do I need surgery? Can I get an injection? They're looking for pain relief now. They're in phase 1. They have a lot of swelling, maybe a lot of pain at night. They can't be on their feet long. They can't be walking. And heck no, their glutes don't activate. They're hurting during the day too. And so what we recommend is only phase 1 exercises. And that's why we have phase 1 available on our website for free. Go check that out, Cindy. Everyone else who's dealing with severe knee pain right now, go start offloading. Go start using the massage gun. There's some basic exercises to do in there. There's a whole section on chemical pain relief, on mechanical pain relief. There's a lot to do for you to get some relief. And that's why there's no magic thing. There's no one thing. It's a combination of things. If you watch the videos in phase 1, you'll hear me say, try two or three things out. That might work for a week or two. Then you need to switch to another 2 or 3 things. It's a process to get this to calm down. And really, that's, I think, a much better approach than what most doctors are going to tell you. If you go to the doctor and they say, oh, your pain's really high, well, you probably need surgery because your x-ray looks horrendous. Let's give you this one pain medication. Come back and see me in a month. That's their one thing they give you to do. No recommendations on offloading. No other things you can try. It's just take this pill. And if that doesn't work, we'll do an injection next. Send you to regenerative medicine. And then we'll send you to PT. They just try one thing at a time. And that's not acceptable in my mind. Great question, Cindy. Hopefully you can get to phase 1 and start applying the program the way I described it there. Gunjan says, does chiropractor therapy really help? For knee arthritis, if we're talking about traditional chiropractic therapy, which is adjustments to your spine, that might give you some short-term pain relief, because I'll do spinal manipulations. I'm a manual therapist, so I know how to do like pop joints in the spine, in the hips, in the knees. And if necessary, I'll do that if I'm seeing somebody in person. However, I tell people all the time, I loosened up your knee, I loosened up your back, I loosened up your hip, but that's short term. You need to fix the muscle imbalances to keep these joints loose in the long term and to take the pressures off the joint. I can't just pop your knee and your knee arthritis is going to magically go away. You have to stop using your quads so much. So when you say, does chiropractic therapy really help? Maybe temporarily. It's a part of the process and it may not help other people. So you have to piece this together and figure out the education on this. Try it, see what you think. Mike Music, he says, I use crutches and in 2 weeks I was beginning to feel better and I could begin to walk normally again. Thank you, Mike, for sharing that. So Mike is offloading. He used crutches to offload. This, in case you've never heard of me talking about offloading, offloading is taking weight off your knee, taking loads of weight off your knee using either a walker or crutches. Mike used crutches. And this is what I highly recommend you guys do. It's probably the best phase 1 thing that you can do to take pressure off the knee, because the knee is a weight-bearing structure. And if it's irritated, it's not ready to take the normal weight that it takes. But if you can take some pressure off of it by getting the weight onto your crutches or onto the walker, and you're not trying to walk around as much as you usually do, then the inflammation starts to go down. And then you hit the next phase eventually. You get out of phase 1 where it's high pain, high swelling. Then you hit the next phase where you can begin to tolerate some more exercise and truly fix the imbalance, and you keep moving forward that way. But you got to start with offloading. Thanks for sharing that, Mike. Super helpful. All right, let's keep going on our lesson here. We're on purple next. So we talked about how important it is to educate yourself about this whole process, about the muscle imbalances and targeting the right muscles, the glutes usually. We talked about how low impact exercise is just so misguided. It's not a good phrase in my opinion. We need to fix the muscle imbalance, not just do low impact exercise. Of some highlight exercises of low impact exercises, walking and aquatic exercise. And then people are always looking for that magical exercise, that one exercise is going to fix everything, but that's a huge mistake. And then pain medications, relying on pain medications is not a good idea long-term. Relying on injections is also not a good idea long-term. A big mistake is saying this stem cell injection, this regenerative medicine treatment is going to fix my knee arthritis. Also a mistake, because it doesn't make your glutes stronger, doesn't take the pressure off your knee. Number 9, what we got here? Mainstream medicine. Relying on mainstream medicine. Huge mistake. Think about this, guys. If you go to the doctor, your typical doctor, because I'm talking mainstream medicine, like if you go to your general doctor, your GP, your PCP, your primary care physician, and you tell them my knee hurts, they're going to take x-rays. They're going to say, oh, you show signs of arthritis. That's probably what already happened to you guys. Then they're going to say, well, I'm the generalist. Let me refer you to the specialist, who's the orthopedic surgeon, the knee doctor. They do knee surgeries all day, knee replacements. Then that doctor is going to probably do x-rays again, maybe do an MRI. And they're going to say, how bad is it? Oh, you're swelling, or you can't walk along? Sounds like it's bad. Well, based on the x-ray, you should have had a knee replacement last year, or maybe you got a year or 2 left on this one. You're how old? Yep, this is age-related. This is the process that mainstream medicine is going to take you through. Then they'll say, well, before we get to surgery, let's try this medication. Come back in a month. Month goes by. Oh, you're still hurting a little bit better? Oh, let's try this injection. Come back in a month. We'll see how that feels. A month or two goes by. Then still not feeling great? Let's try physical therapy. They'll stretch you out and move you. Then you go to physical therapy, your general physical therapist, and you pop into the clinic and you're looking around and you're seeing, oh, Mary had a knee replacement and Frank had a knee replacement and everybody else here is here for some post-operative situation, back surgery, shoulder surgery. This kid had an ACL surgery. Most people here have had surgery because that's what mainstream medicine leads you towards. And so the physical therapists are great at helping people recover from surgery, but you're trying to avoid it. You're trying to fix knee arthritis before you need surgery. So guess what? You're in the wrong place. You're trying to get advice, guidance from a physical therapist who's an expert at helping people recover from surgery, not avoid surgery. But you follow the mainstream medicine model. So you go to the regular physical therapist and they say, knee arthritis, let's get on the bike, let's get on the treadmill, let's walk, let's do quad exercises, let's do quad sets, let's put the rubber band around your knees and open and close your knees together. And you look around and you see, well, these are the same exercises that Mary's doing for her knee replacement. And it doesn't click in the moment because you're just following what the expert is telling you. And what's actually happening is that physical therapist doesn't really know how to fix knee arthritis. They know how to rehabilitate people after a knee surgery, like a knee replacement. And so what they're just doing is following a default. They're saying, well, generally people have quad weakness, so we're going to work out their quads, and they just need to move more, so we're going to get them on the bike. We need to loosen this up, so we're going to have them walk. Pretty general stuff, which is appropriate if you've had a knee replacement. And keynote here is after you have a knee surgery, when you have a knee surgery, especially like a knee replacement, and they're cutting open your knee, they're taking out your kneecap, they're sawing off the ends of the bones here because they're going to replace it with metal prosthetic parts. They open you up massively. And in order to do that surgery, they have to put in, what is it called? Oh my gosh, the name slips my mind, but there's things that they put in your quad muscle to inhibit the activity of the quad muscle. They put medication in your quad muscle. You guys comment on here. You guys probably know about this. The name slips my mind. But you'll have a medication that shuts down your quad muscle so that it doesn't activate. And after you're done with the anesthesia and you come out of the knee replacement surgery, your quads won't work. After you have an ACL surgery or a meniscus surgery, your quads are shut down. So it makes sense for that physical therapist who rehabilitates people after surgery to work your quads. Nerve blocks, that's what it's called. They put nerve blocks in your quads. They block the nerve signal to the muscle so that your quads don't all of a sudden activate mid-surgery. That would be disastrous for the surgeon and you. So you have that medication still in your body after the surgery and your quads don't work. And they have to make you work your quads to get them to work. But the thing is after the quads are working, you now need to work on your glutes, and those therapists never really connect the dots and they just keep working your quads. So you finish your physical therapy as the surgeon recommended, and you might maybe actually get worse. You go back to the surgeon. The PT might even say, hey, PT isn't working out for you. Go back to the surgeon. Then the surgeon says, all right, we tried everything. We tried medications. We tried injections. We tried physical therapy. We even tried some hyaluronic gel injections or some stem cells or some other regenerative medicine stuff. We tried the new stuff. None of that worked. Now we have strong evidence that surgery is the next best choice. That is where mainstream medicine will take you. Meanwhile, nowhere along this pathway were you told you have a muscle imbalance. Your glutes don't even work. You're using your quads too much. There's too much pressure in your knee joints. Learn how to walk with your glutes and not use your quads so much. You maybe need to get stronger in your feet or your abs. There's a bunch of other things to work on that nobody in mainstream medicine is going to tell you because it's not their training. They're guiding you towards surgery. That's where the path leads. So it's a huge mistake, in my opinion, if your goal is to avoid knee arthritis, a knee replacement. Let me say this clearly. If your goal is to fix knee arthritis so that you can avoid a knee replacement and thrive in life, not just survive. I mean, thrive, like get back to doing everything you love to do, then you should probably not follow mainstream medicine. You need to find alternative medicine, like what I'm doing here. Maybe there's somebody in your town that's similar to what I'm doing. I would lean towards that. All right, hopefully I ranted on that one enough. And you guys, I think you guys all get it here. There's some of you guys that are new maybe that are learning all this stuff, and I need to go on that rant for you. All right, number 10, as I was already alluding to, big mistake to focus on quad exercises. You're shooting yourself in the foot. You are committing knee suicide if you're doing quad exercises, because it is directly going to pull the kneecap into your thigh bone. It's going to further compress the cartilage in the back of your kneecap and on the front of your thigh bone. And then because of the way the kneecap is connected down to the shin bone, you're going to yank this tendon upwards as these quads get stronger, and you're just going to smash your meniscus and smash all the cartilage between your thigh bone and your shin bone. And you're just asking for your knee arthritis to go faster, to get worse faster by doing quad exercises. The thing is, you may not always feel instant pain right away as soon as you do one quad exercise. It may take you some time. As the quads get stronger, you'll feel it. Some people do get instant pain. Some of you guys are watching this, you're like, oh, it hurt me right away as soon as I did a quad set or a knee extension. But some of you guys actually tolerated it for a bit, and then you started to hurt. And those are the ones that I get worried about, because you guys get feedback that it's good for you and it didn't feel bad. And then you keep going, and then you're left scratching your head thinking, well, I was doing stuff that was working and now it's not. Doesn't make sense. And it's because of the muscle imbalance. That's the piece that you're missing to connect it. So don't do quad exercises. That's a big mistake. All right, 11. My marker's just getting funny here. Stretching. I've met people consistently. I meet one every couple of months or so. They're like, stretching is the solution. Do this stretch and that. You got to lengthen the quads. You got to lengthen your hip flexors. You got to also stretch the back and the hips, and they'll bank on stretching. And what I consistently tell them, and I see it happen too in these people, is stretching will feel good at the beginning. It probably will. It typically isn't very harmful. There are situations where it can become harmful. I'll tell you about that. But stretching usually frees things up. The problem is it's short-lived. The benefits of stretching are only going to be there for hours, a day at most. And you get diminishing returns as you continue to stretch. What I mean by that is, if you stretch for a few days, you're going to feel like it's helpful. But then after a few weeks, you're going to feel like you don't get as much benefit for the same amount of stretching that you did. And what people who stretch a lot find themselves doing is stretching for longer or stretching more frequently. They'll say, well, I was only having to stretch 20 minutes in the morning, and that helped me out quite a bit. You know, I was good until the evening. Now I found myself having to stretch for an hour to be good until the evening. Then a few weeks pass, and they're saying, well, now I'm stretching 20 minutes here, 20 minutes there, 20 minutes. 2 hours total spread out throughout the day, and that's how I'm surviving. And what they're not realizing, and I have to point out to them, is the stretching isn't working for the long term. You're trying to apply stretching to make it fix your knee arthritis long term. Your plan is to stretch more to affect your knee arthritis more, and it's not working. You're going to run out of stretching time, and people get to the point where they're saying, I'm just stretching all day. And I say, yeah, because you're not fixing the imbalance. Stretching doesn't make your muscles stronger. You need to focus on getting the glutes to activate. You need to fix the imbalance, educate yourself about that, and get those glutes to activate. So it's a mistake if you just pursue stretching. All right, I'll fit 12 over here. Oh, we were talking to Doug about this one. I'm just going to write WT, weight loss. Weight loss. So if you have a lot of weight to lose, if you were here for Doug's call, rewind it. If you're catching this in the replay, or even if you're live right now, you can rewind. If you were here for Doug's call, Doug's BMI, body mass index, it's a ratio between your height and your weight. Oh, do we have the image here that we can flash? That'd be helpful. If your BMI is above 35, which Doug's was 38. There's the chart. There we go. So you can see the red zone, the first red zone right above the orange zone, which is 30 to 35. We have found that you can still make some serious improvements in your knee arthritis by following our treatment approach in the knee arthritis recovery program if you're in that first layer of the obese red zone. If you're 35 or under, you're good. Doug is in that next tier above 35, between 35 and 40. Well, we found, yep, right there where the arrow's at. I don't know if you can see the arrow. We're moving with the mouse over here. But if you're in that 35 to 40 zone, you should focus, even if you're above 40, you should focus on weight loss first. And the reason is, if you come back to me, is because above that weight, what we're determining here, this is just from the experience we've gained in our program, the knee arthritis recovery program, is the weight is too much to overcome by the gains in strength you're going to make through the program. And so people that are at a higher BMI aren't hitting success early on in the program. And what we're telling them now is, like I told Doug, go lose weight first. And it's going to be beneficial for so many other reasons anyway. You might have a heart problem, a blood pressure problem, a diabetes problem. There might be other health conditions. I don't know what Doug's dealing with, if anything, but you might have those issues. And if you bring that weight down, it's going to help all those other issues. Plus, it's probably going to make your knee feel better and then get you to that 35 BMI or lower, to where now our program, the knee arthritis recovery program, is going to be highly impactful for you. Once you start applying the program, you're going to notice consistent improvements. But if your weight's too high and you try to apply the program, you're going to stall in our program and you're going to feel like it's not working for you. When it actually will work for you, it's just that weight's a higher priority for you at this time, at your current weight. And if you bring it down, you'll be all right. So the mistake people make is when their BMI is too high, above 35, they're focusing on trying to do exercises. Not a good idea. Go focus on eating less, on talking to the doctor about a medication you might need to be on dealing with any other conditions that are causing you to add more weight. Whatever it is, I'm not an expert in weight loss. Go get the right kind of help or take the right actions to drop that weight in a safe way so that you can be 35 or under and begin our program. Now, if you're 35 or under, notice that 30 to 35 section on the graph is red and is considered obese. You're technically obese, which it could be more muscle, but still you're heavier than you should be according to the chart. But we found that people can actually benefit from our program quite a bit. And so if you're focused on trying to lose weight and your BMI is actually 33 and your doctor saw you and said, can you lose 20 pounds? Can you lose 30 pounds? That's going to make your knee arthritis better. I have talked to so many patients that do not have a super high BMI. They're 33, 34, or 30 even. And they're saying, I've been trying to lose weight. I've been eating this. I started this diet. I started this medication, this and that. And they're very focused on weight loss, and they don't need to be. And if they just got their knee feeling better by doing our program and they stopped focusing on weight loss, that's the mistake they're making. And they actually focused on getting the glutes to activate, on walking with the glutes, on fixing other problems that we cover in the knee arthritis recovery program. They will feel so much better without focusing on the weight. And usually then they're able to walk more and be more active, and the weight comes off a lot easier. Those last 20 or 30 pounds that they're trying to lose so intensely. So weight loss is a mistake, and on both ends. Like you might not be focusing on it enough if you're too high, and you might be focusing on it too much if your BMI is below 35. Take that one into consideration, guys. All right, final one, 13. Not offloading. That was the other call we had. Was it? I forgot the gentleman's name. Not offloading. I'll just write that. No, it was the call that it took. James, that's right, from Pensacola. He was talking about the abs. There was somebody who was talking about offloading. Anyways, the offloading. I was talking to James about offloading. He was talking about using the crutches, I think, or that was James. I'm confusing the two. Anyways, just stay on track here. Offloading is when you take weight off your body. Let me show you. You're either going to be using crutches We lent out the other crutch, haven't gotten it back yet, but you should ideally have 2 crutches and you're putting weight through the crutch so that you're not putting your full body weight through your knee. Crutches is one option and works for a lot of people. You might need even more support though from a walker, and it works almost the same way. You're just leaning your weight on the walker so that you can keep this leg off the ground, the one that hurts you. And if you can spend some time, like Mike was saying, a couple of weeks, it'll make the world of a difference on your knee pain. And because remember what I talked about back with somebody asked a question of when should I get a knee replacement? The 2 factors doctors are looking for, those orthopedic surgeons in the mainstream medicine, they're saying, is there evidence of knee arthritis on your x-ray? And then when is it bad enough? When are you ready? When are you desperate enough that you'll do surgery? Those are the 2 factors that the doctors are mainly looking for. I strongly believe that probably 90% or more of people that are signing up for knee replacements are 2 weeks away of offloading, 2 full weeks of offloading away from feeling like they don't need to have a knee replacement. That second criteria that the doctor said is how bad is it? If they just spent 2 weeks on some crutches or a walker, they would probably be saying after those 2 weeks, you know what? It's just a little stiff in the morning. Yeah, I have something, but I don't think I need surgery. But they're so bad because they've never been guided. Nowhere in mainstream medicine did they ever get told, get on some crutches, get on a walker. In fact, the only time they'll tell you in mainstream medicine is after you've had the replacement done. Then it's mandatory. You need to be on the walker. It's too late then. You already had the surgery done. Why don't you spend 2 to 4 weeks, maybe 1 for you, maybe a month or 2. It depends on how severe your situation is. But if you put in the time to properly using the walker, maybe getting the crutches, and get off the knee, and deal with people asking you, oh, what happened? Why are you on a walker? And you just deal with it. Just, yeah, I'm doing this thing and I'm going to be better. I haven't had surgery. I'm actually avoiding it by doing this. And just have your explanation ready to go and take the walker with you to the store, ride the motorized buggy at the grocery store, the big department stores, the Costco's, the Sam's, all that stuff. And just get off your knee. And within a week or 2, a month for sure, you're going to probably feel tremendously better. Now, you didn't fix the muscle imbalance, but you brought down the irritation levels, and it puts you in a place where now you can fix the muscle imbalance. Because when your pain was so high, you can't think of anything else but going to go get it cut, going to go get that replacement done. You're giving up. You're throwing the towel in and saying, surgeon, take over. I'll be there at 5 a.m. for your first surgery. When you just needed to offload. So many people make that mistake of not offloading. And I hope that you guys don't make that mistake or any of these other mistakes. All right, guys, that covers my teaching for today. I'm going to answer comments. Let's see what you guys got here next. Ask me some questions. Let's make use of this time and make sure you guys get helped. Steve Drake says, I disagree on your BMI thoughts. I think we need to be below 30 BMI, but you can still do your exercises to help anyway. Well, Steve, this is data that we've gotten from our program. Like we have started tracking people's weights. We started asking questions. We started to investigate because we started to see the people that were too high. And we got some numbers and we saw that 35 and below, 35 was the cutoff. I agree you should be even lower in weight if possible, if it's healthier for you. But we found that even people that are in that 30 to 35 zone, that first line of the obese section, they actually still improve in our program. But once they were above 35, we saw people did not make improvements, and we started to guide them towards losing weight instead. That's a higher priority for them. So that's where I'm getting that data from. Good question. Mimi says, I have atrophy of glute on the side of hip OA. I'm really struggling to activate this glute. Would EM, electrical muscle stimulation device, be helpful to jumpstart? Yeah, I think so. I think it's worth a shot. At least to start. Ultimately, you have to have that conscious control over it. but I think it's worthwhile to get the electrical muscle stimulation. So there's these devices that are sold on Amazon. You can even get them at some stores in your town, probably. You could definitely go to like a doctor's office. Usually like a chiropractor will have them in their office, or a physical therapy clinic might have them, where they put these sticky electrodes that have like a little button on them that you snap a wire to that's connected to a machine, and the machine, you can turn on electrical signals to go to the electrode, and it'll make your muscle kind of squeeze and activate. It'll force your muscle to activate. What I would do if I were you, Mimi, is I would get a hold of one of those machines. They're not that expensive either. I think you can get them for like $30 to $50. And they take batteries, I think maybe 9 volts or several AA batteries, and hook that up, put them on your backside, and just on the side that you want to activate, crank it up comfortably. And then it will usually have a setting where it activates and then it lets go. And there's like a rhythm to it. And once you figure out that rhythm, you need to then consciously activate your muscle, like try to make your own muscle activate when you get the electrical signal from the electrical stimulation device. That way you're taking advantage of the electrical stimulation, and you're making your brain make the muscle activate too. That's, I think, a good way to start if you're really struggling with this. But I would still be practicing without the machine, just to make sure that you're not relying on the machine. Good one, Mimi. That's great. And some of you guys are probably, laughing at that one, but I'm serious. I think it's necessary for some of you guys. You guys don't have glute activation, and it's so severe that some people don't believe the glutes even exist. We've dealt with this. Julie Parker says, no, I stretched my hamstrings, and the last one, my left knee's bending ability got a lot worse, and still hasn't recovered. That was last year. So Julie was stretching her hamstring and actually got worse afterwards and still hasn't recovered. Yeah, so that's the harm. I don't think I mentioned it about stretching. Is it's usually not harmful, but the situations where it can get harmful is if you're stretching intensely. You can injure the muscle, you can tear the tendon where the muscle connects to the bone, and you can actually injure the joint that it affects too. And this is only if you're going intensely. So what I recommend if you do stretch is on a scale of 0 to 10 intensity. 0 meaning you don't feel anything at all, and then 10 meaning you're a little bit of pressure away from injuring yourself. What I recommend you stretch at is like a 1 or a 2, very low intensity. If you stretch at that low intensity, you run a very low risk of injuring yourself. But yeah, this already happened to you, Julie. I'm so sorry to hear that. But good lesson to learn for yourself and everybody else, that you cannot be stretching intensely. I don't think it's a good idea. There's this thing called the stretch reflex that you'll set off. You can Google it, where the muscle actually contracts. The muscle you're trying to stretch will eventually begin to contract once you hit a certain threshold, and that's what begins to cause the injuries. You want to avoid that intensity. Good question from Julie there about stretching. Gina says, knee pain is putting a damper on my quality of life. I'm active at the gym. I do take classes, and I modify lots of quad exercises and use my glutes when squatting, and have incorporated glute exercises daily while at the gym. I cycle and focus on glutes. I've also lost 40 pounds and still can't walk comfortably. Am I just not focused enough on my glutes? It's been many months now. Oof, that's tough, Gina. So 2 things come to mind with this, with the situation. Number one is, you said modify lots of quad exercises. So that makes me think you're still doing some quad exercises. Maybe you just made them a little bit easier. I would cut them out completely. That might be something that's slowing you down. That's thing number one. Thing number 2, well, actually, there's a third thing that I just found. But thing number 2 is, perhaps your knee pain is bad enough right now that you should not be doing exercises, and doing all these exercises, even though they're good exercises, a lot of them, it's not time for you to do exercises. That goes back to this chart here. You might be qualifying for phase 1, and in phase 1, I would not have you do gym exercises. Gym exercises don't come into play until the late end of phase 3, definitely phase 4. And if you're having pain 4 to 7 days a week at night or during the day, or swelling 4 to 7 days a week, you have no business in the gym. If you can't be on your feet for more than 10 minutes, and if you can't get your glutes to activate appropriately, then you need to be not in the gym and doing some other basic exercises. And the thing is, this is tough, especially if you're a gym goer. You know, I'm a gym goer. I go to the gym almost every day. And if I can't get to the gym, I feel like I'm going to go crazy. I need to go move. I need to go exercise. I need to go get a sweat. And so I get it. And it's immense restraint to say, I can't do what I'm used to doing. But you have to go through that in order to let your knee calm down. And the third thing that I found here is you said you lost 40 pounds. I don't know where you started, but if your BMI is above 35, like I was saying, you might still need to focus on more weight loss. And all this exercising, you're probably telling yourself, like, I need to exercise to lose the weight. Yes, but also, you know, what you eat, the calories in versus calories out. You got to be playing with that ratio to get your weight under control. I don't know what your BMI is right now. It might be good. It might not be good, like above 35 or below 35. That's the cutoff that I use. So hopefully that helps you, Gina. Just 3 areas to look at to see if we can get some traction here. Steve says, I reached that can't take it pain anymore last summer and had the left total knee replacement. I've been doing your exercises for many years and I'm delaying the right total knee replacement as long as possible. Sometimes it's really necessary. Undeniably, yes. Like, there are some people out there that need to have the knee replacement. I've always said, like 9 out of 10 or most people can avoid a knee replacement. Like I was saying earlier, I think 9 out of 10 people, 90%, over 90% of people that are signed up for a knee replacement right now are just a good 2 weeks away of offloading, from getting off the surgeon's list schedule. But there are some situations where we tell people, if your motion is bad and it's been like that for months, you probably do need to have the knee replacement. So don't feel bad about it, Steve, as long as you know. This is why the education comes into play, because if you have good, solid education about muscle imbalances, about what you should expect, if you go through the knee arthritis recovery program and you absorb the information in our program, and we're an educational program. If you learn that and own the knowledge, then you can have much better certainty going into the surgery saying, this is for me. I know that I should have surgery. And I think that's powerful, rather than living with regret or uncertainty after the surgery and thinking you could have done something different. So you do you, Steve. Kathleen says, is knee arthritis secondary to meniscus tears different than arthritis due to non-traumatic cases? This is a bit of hair splitting for me, because, okay, so really it's traumatic meniscus tears versus non-traumatic meniscus tears. Both situations are going to get knee arthritis, but very high chance. I would look at the muscle imbalance. Like I think it's indifferent. I'm indifferent about what the source of the meniscus tear was, because if you had a sports injury, a traumatic meniscus tear, if you were in a car accident, if you were in some accident that you think caused your meniscus tear, I still raise the question of, did you have the tear there before, but you never had an MRI until the injury, until that traumatic event? It just so happened to twist your knee or bang you up in a certain way that your knee started to hurt, and then you found out about your meniscus tear. Versus the person that never had an accident, they never had a sporting injury or any kind of other accident. They just started to get knee pain, went to the doctor, and they found the meniscus tear. It's hard to say. Both situations, though, likely have a muscle imbalance. Weak glutes, over-dominant quads, possibly over-dominant hamstrings too. That often happens. And that needs to be corrected no matter what. So I wouldn't split hairs over it. I'd say they need the same treatment. So hopefully you fix that, Kathleen. Esperanza says, I'm using LED therapy and it's helping me. I would like to know how often a week I should do it. Good question. I'm not an expert in LED therapy. That's the light therapy, laser emitting diode, or light emitting diode therapy. There's like usually red lights that they use for this. Red light therapy is another name for it. It's something about the wavelength of the red light. That's what I've heard. I don't know. I would say use it as frequently as whoever you got it from said to use it. Maybe you can modify it a bit from there. I am not an expert in it. What I would also say to you, Esperanza, is you need to fix the muscle imbalance, and light therapy is not making your quads less dominant or your glutes stronger. It's just helping with the pain, and that's short term, and that's okay. But you have to make sure you fix the muscle imbalance. KK Hoffman says, do bucket handle meniscus tears need repair or surgery? It depends on your knee function, because you might have a bucket handle meniscus tear, but you're feeling okay. Your knee joint isn't locking too frequently. Then I'd say you probably don't need surgery. But if your knee joint is locking all the time, like, and what I mean by locking is like your knee can't straighten and it hurts and it's painful and you have to kind of wiggle around to loosen it up and get it to straighten out. And if that's happened to you several times a day, then there's a higher likelihood chance that the tear is that flap that's in there from the meniscus tear is obstructing your knee function, and surgery might actually be beneficial at that time. And I would still say go fix the muscle imbalance before you have the surgery, because if you fix the muscle imbalance, you might realign the knee a little bit better, because that happens, and your knee might function better without surgery. So it's hard to give you a black and white answer of yes or no. Marty says replacement fail. I'm so sorry, Marty. Scar tissue may be an issue. I think it is the muscle imbalance, maybe both. Have good core strength. Good. What program for getting glutes to work without feeling other muscles fire? So sorry, Marty. That's tough. Yes. So Marty had a knee replacement and is still hurting her. So we have a program called the Failed Knee Replacement Recovery Program. I would go to that one. But if your other knee, if you have another knee that is not operated on and it's giving you issues, it potentially also has arthritis, I would go to the Knee Arthritis Recovery Program. We have a lot of people that are members of the Knee Arthritis Recovery Program that are in that situation. They had one knee replaced and it's not great for them. They've had issues and they don't want the other one replaced, and the other one's giving them problems, their other knee. And so they're looking to avoid surgery on their non-operated knee, and they're in our program doing fantastic. And very often their knee that got replaced is improving as well. And a lot of them are scratching their heads and they're saying, did I even need surgery the first time? And I'm like, I don't know. I didn't see you before that. I don't know what situation you're in. Either way, we're here. We're fixing the root problem. Hopefully both knees get better. Good question here. And Mather says, what about the lymph nodes behind the knee? Good question. I am not a lymph specialist. I do not know much about that. There are lymphedema doctors, lymphedema physical therapists out there, and that is not my specialty. Now, there's Baker cysts that can cause swelling. That's swelling behind the knee joint. Do I have my knee joint somewhere? Where did it go? Oh, thank you. So here's the knee. That's the front of the knee where the kneecap is. And then on the back side of the knee right here, that's where the Baker cyst will develop. And what it is there's a covering here that covers that makes the knee joint capsule. If there's a lot of pressure in the knee from the muscle imbalance, sometimes people will respond by getting a lot of fluid to develop in an effort to pad the joint, to put some space in the joint here. But that fluid, because it's a tight joint, it doesn't have much else to nowhere to go, and there's a kneecap in the front which kind of obstructs things, but there's no kneecap in the back, so the fluid will pocket outwards and cause that Baker cyst back here. That Baker cyst to me is a sign of knee arthritis, because you have excessive fluid development, usually as a response to excessive pressure and irritation inside the knee joint. Now, if that's your source of swelling, Anne, then I would say fix the muscle imbalance. But if you know for sure it's lymph nodes, then I'd say go see a doctor about lymph nodes. I can't help you with that. And this program isn't designed to help lymph problems. Lucinda is on Facebook. She says, my psoas was injured 10 years ago and never addressed. I am now 4 years wheelchair dependent. Is there something I can do to help it heal? I'm living alone without access to outside resources. Thank you. Oof. I would want to know what was the extent of the injury to the psoas? Because if it was like torn, if it's not connected, if the tendon or the muscle got disconnected, then it's going to be hard to recover. There's other muscles that can compensate, but I don't know what the status of that is. Now, if it's just a strain and it's become chronic, like it's just been hurting a lot, if the muscle's very, very tight as a result of the strain, then it could be that it's doing that because you have weak glutes or weak abdominals too. Weak abdominals can cause the psoas to not function normally. And yeah, it can keep your hip flexed and not allow you to stand and move normally, which could set up the wheelchair situation. So I would go back to, can you begin to fix the muscle imbalances, which is usually getting stronger glutes, getting stronger lower abdominals. That usually helps the function of hip flexors. Hip flexors tend to overcompensate for weaknesses in the glutes and the abs. And it can, when they overcompensate, they get very active and they get tight and it can become painful. And that's what usually leads to hip arthritis, knee arthritis, and pain with weight bearing. So I'd say fix the imbalance. That's the number one thing you can do. And that's going to go to our phase 1 of our knee arthritis recovery program or our hip arthritis recovery program. For those of you guys that have hip arthritis, we have phase 1 of the hip arthritis recovery program available for free on our website too. And so I would start there, Lucinda. Good. Monica. Pes and Serene is inflamed on the daily, quite painful to manage. Any tips to release the tension? So Pes and Serene is the medical term for the 3 tendons that all come together and converge, and they come on the inside of the knee right here. So there's a bursa, which is a fluid-filled sac that just keeps the tendons from irritating the bone too much and on each other. So you can get Pes and Serene bursitis in this area. So that's what they're talking about here. What was the name again? Monica. So if it's inflamed there, it's hard to know if it's the bursa or the tendon. Either way, what I'm thinking is there's probably a muscle imbalance setting this up. I've made videos on this. I think I've got a video on Pes and Serene bursitis. And what often happens, if you look at my knee here, is if you come inwards like this, if you tend to move inwards like this, which you're not going to know that you do unless you pay close attention. But when you do that, you add tension to the inside of the knee, which tensions the Pes and Serene tendons as well as the bursa that's there. And the reason, the main reason that knees come inwards like this, like when you're just sitting and standing, people will go to sit down. And then when they stand up, their knees go like this, and then they stand up. And that happens very often because of weakness in the glutes in the back of the hip. Because the job of the glutes is to turn your thighs out and maintain them in this position. And if you tend to sit and stand with weakness in the glutes and dominance in the quads, it'll cause your knees to go inwards when you sit and when you stand. And if you're an exerciser and you're doing squats like with the barbell and you have weak glutes, it'll tend to make the knees come in like this, and that can put tension on the inner knee as well. You can get Pes and Serene bursitis, saphenous nerve irritation, meniscus problems, all kinds of inner knee pain issues will happen if you don't have good glute strength. You have to make sure that, and it's not just the strength, but the coordination. They're 2 separate things, because you can have excellent glute strength, but you don't use it when you need to. You're not thinking about using your glutes when you go sit down or stand up or when you go upstairs, because every time you go upstairs, your knee might cave in a bit. And you have to become very conscious and aware to fix a coordination problem. And that might be what solves your Pes and Serene issue. Good question, Monica. Gigi says, this all makes so much sense to me. I've always been told I have a flat butt, and now I'm trying to follow doctor's protocol and strengthen my glutes. My knees are hurting. Thank you, doc. Yes, this happens so much. And, you know, women and men, body shape differences, obviously. Women tend to be more curvy, so it's less noticeable usually in women that they lose their butt. Men tend to be more noticeable when they lose their butt as they get older, but it happens to women where they do lose their butt. Or I've had it a lot of times where I get a woman who's in their 60s or 70s, and I test the glute. There's a special test that I can use to test the glute, and they fail it miserably. And then I tell them, your glutes are weak. And they'll say, yeah, I couldn't hold that up. And then they start scratching their head and they say, but I have a big glute. Why am I failing the glute test? And I tell them, it's just your body shape. Just because you have bigger hips doesn't mean that your glute muscle is working properly or that it's even strong. It's probably more just the shape of your body. It's other things, adipose, that's giving you that shape. And that's normal in women. That's how they're built. So just be, what I'm trying to do with this conversation here is make you ladies that are watching right now hyper aware that if you're thinking right now, I don't have weak glutes, I have glutes. I have my lady curves and therefore I have glutes. No, if you have knee arthritis, you probably have weak glutes and you're not using them properly if you have good strength. And for you, Gigi, I'm glad you're aware. Maybe it's obvious for you that you have a flat butt. Now you know what to work on so you can fix your knee pain. Thanks for the comment, Gigi. Cookie says, Cookie in Florida, headed to El Paso this Saturday. Hey, glad that you're coming to my hometown. Thanks to you, I have learned to engage my glutes. Awesome, Cookie. Glad you're using your glutes. Now let's get them stronger and let's keep your joints healthier. Good job. Cookie says, I have been following you for a couple of years, told I need new knees. Your program works. Fantastic, Cookie. I'm so glad that you've been in our program and that it's working for you. And so I assume then you avoided a knee replacement, 2 knee replacements, and you did our program. That's awesome. Fantastic. This program works. It's insane how great it is. Carolyn says, I am bone on bone, both knees. I do chair exercises daily. I will not do surgery because it will not work out for me in my situation. I use a cane and a walker at home, wheelchair in public. Okay, let me read this again. It will not. Okay, the surgery won't work in my situation. I use a cane and walker at home, wheelchair in public. Got it. Good job, Carolyn. I'm glad you're doing the exercises, and I'm glad you resolved in surgery. Just be mindful that there are some situations that need to go to surgery. However, it looks like you've got good momentum in working your glutes out, and I hope and pray that you can fix the glute strength and fix your knees so that you don't have to be relying on a wheelchair and you can get around easier. All right. So I was saying earlier about this program, how it works before I answer this comment. This program, there's nobody else out there talking about fixing the root muscle imbalance. There's a lot of healthcare providers out there that will say there is a muscle imbalance, like they recognize that there's something about the muscles that's causing knee arthritis or hip arthritis or other knee and hip problems, but they haven't defined it like we have here in this program. And the way we've defined it, we've also developed the ways to fix it. That's why I talk about the education and understanding how the quads and the glutes work. And it's not just a copy and paste cookie cutter situation where you just do this list of exercises and you're good to go. You need to own this knowledge so that you can enter your specific life situations and the next ones to come and know how to apply fixing the muscle imbalance to your situation so that you can consistently heal. Because I get people all the time, they're like, oh, I got these new insoles and they're making my knees feel better. And then later on, I ask them questions like, well, what are you going to do when you go to the pool? Do you wear those insoles in the shower? What if you need to wear some nice shoes and the insoles don't work with those shoes? But there's all these situations that where that plan fails. But fixing the muscle imbalance, it applies to your whole life. If you can do this correctly, you will get to doing all the things you love to do. You will thrive. You won't just skip the surgery and barely survive, in pain, on pain medications, having to do nothing. You will get back to doing all the fun things you like to do, but you have to apply this program properly, and you have to start with the education. Do not be uneducated about knee arthritis, guys.
2 questions about the program.
All right, we got some program questions coming up. Chantal says, how much does a knee recovery program cost? What should I do if I am located in Germany? And then Caroline Shipsy says, hi, Dr. David, how much time needs to be devoted to the program daily, please? Good questions. Let me answer the first one about the cost of the program. It depends on the amount of time that you want in the program. There's a few things that you need to take into consideration, like how bad your muscle imbalance is, the severity of your situation. My recommendation to determine the cost is to talk to us. You can apply to our knee arthritis recovery program. You can apply to join the program. We have on our website, you'll see where you can apply. And once you submit the application, you'll be prompted to do a safety interview. We want to make sure that everybody's safe. So make sure you book that safety interview. And if you pass the safety interview and we say you can do the program, then we'll talk to you about the specifics of what you need for the program. And of course, you make your own decisions on that, but we give recommendations. And if you're in Germany, if you're out of the United States, you can still be in our program. We have people all over the world in our program, people in in different parts of Europe, in different parts of Asia. We have people in Australia, a lot of people in the US and in North America and in South America too. So no fear, you can be in our program even if you're not in the US. Now, for the other question, how much time needs to be devoted to the program daily? Let me answer that using this chart. You will learn this chart quite a bit if you're in the program, because we'll refer to it a lot. It's very important. But to put it simply for you here, Caroline, if you're in this phase, you're not going to be doing a lot of exercise. In fact, it's going to be more adjusting your schedule so that you don't flare up. It's going to be do less, really, like kind of sit around more and use your massage gun and do little simple exercises. So it depends on how you look at it. It might free you up quite a bit because you're a busy person and you like to be busy doing things. You actually will slow down. But if you're somebody who's not doing much right now, you might actually have to ramp up your thoughts about how to implement this, which some people will say that it feels like they're doing a lot all the time. So phase one is kind of interesting in that way. Now, phase two, this does get busy. I tell people often in phase two, you need to be doing some exercise every hour for like a minute or two. It's not a full hour of exercise every hour, literally exercising the whole day. You're just doing something to make a certain muscle burn and work every hour because you need that frequency, because you can't tolerate 20 minutes of exercise. It's going to flare up your knee. But you can tolerate a minute or two, and that's beneficial. And if you can do that 10, 15 hours a day, then you're going to make a lot of progress. And so we recommend doing something hourly. Then when you get to phase three, you're doing more like workout type things. Like you're doing like a 30-minute workout to maybe a 45 or an hour workout. Depends on your situation. You have to adapt this to you. And that's going to be daily usually. Then by the time you get to phase four, you're working out like a typical person would work out. You're doing 3 to 4 gym style workouts a week. And then on the days that you're not going to the gym, you're doing some sort of cardiovascular exercise, which could be walking. It doesn't have to be super intense, but you're trying to exercise every day, which is what we should all be doing to some degree, as long as you can tolerate it. So it varies. So in case you didn't catch all that, rewind the video here, Caroline. Those of you guys that are wondering too, it varies is my best answer as far as the time commitment. But the question that I would ask, I know you're weighing this, like how much time is it going to take? The question I'm going to ask though is how much time is it going to take you to deal with a knee replacement that failed? What's your quality of life going to be like if that knee replacement doesn't work out the way you planned? For a lot of people, they have a lot of problems afterwards. Are you willing to deal with a failed knee replacement that needs a revision, or you need to have a second knee replacement? Those are the risks that you take on. But if you carve out the time to do the exercises, to do the learning that's needed in the knee arthritis recovery program, the payoffs are enormous for you guys. You will live a much happier, higher quality of life with little to no pain if you fix the root problems that the knee arthritis recovery program is designed to fix. Guys, thank you so much for joining me on this call. I will be here next week with you guys.